Good morning, everyone. I am Shani Mativar from the University of the West Indies HU Center for Health Economics. I am pleased to have you with us today. I will be your chair for today's session. Today's webinar is a collaboration among several partners from the International AIDS and Economics Network, from the Pan-Caribbean Partnership Against HIV and AIDS, and from the University of the West Indies HU Center for Health Economics. The focus of today's webinar will be on the next and last pandemics, the consequences of COVID-19 and its impact on the HIV/AIDS response. In terms of the order of today's activities, we will begin with a welcome and some opening remarks, followed by an armchair discussion, which will then have a question and answer segment. Then we'll hear some closing remarks. First, before we begin, I'd like to just outline some housekeeping matters. Please keep all of your mics muted. There will be a question and answer session. You'll include your questions using the Q&A tab on your screen. You can pose your questions either directly to one of the panelists, or you can leave it open for any one of the panelists to respond. So now I'd like to introduce our first speaker, who will bring some welcome remarks. This is Dr. Stephen Forsyth. Dr. Forsyth has a total of 30 years of experience in the area of HIV and AIDS and economics at Avenir Health, the Instituto Nacional de Salud Pública in Mexico, the Futures Group International, the Liverpool School of Tropical Medicine in the UK, and the Family Health International. Stephen Forsyth has a doctorate in health economics with extensive experience working in areas including resource allocation, costing, socioeconomic impact assessment, and workplace intervention. Dr. Forsyth conducted a PhD thesis in Kenya, where he analyzed how people value HIV/AIDS service using contingent valuation. Dr. Forsyth has worked in more than 100 different countries. Dr. Forsyth has published widely in the field of HIV and AIDS, in journals, 5 books, technical reports. He's also the co-founder and current president of the International AIDS and Economic Network. In addition to his work on economics and AIDS, Dr. Forsyth has also conducted several recent analyses on the economics of COVID-19. He recently completed economic analyses in Tanzania and Burkina Faso, and is beginning work focused on COVID-19 in Mozambique. He also recently launched a LinkedIn group called Economics of COVID-19, which is designed to be a forum where research can be shared on the economics of the pandemic. With that, I'd like to introduce you to Dr. Stephen Forsyth. You have the floor.
Great. Thank you very much, Charmaine. First, thank you very much for joining us today for this webinar. I'm Stephen Forsyth, the president of the International AIDS Economics Network and a health economist with Avenir Health. I'm proud to join colleagues at the University of West Indies, HEU, and PANCAP to lead this webinar, which we hope will be one of a series to look with an economic lens at the two pandemics. Now, economists have argued that pandemics often have short-term epidemiologic impacts and long-term economic impacts. The Black Death and the 1918 pandemic both had critical long-term impacts on labor, salaries, politics, culture, and economics. Given the change in demographics, including the large debt incurred by many countries, inflationary pressures, unemployment pressures, and the significant changes in the way people work, shop, and travel, it's argued that the economic impact of COVID-19 is likely to be measured not just in months or years, but in decades and generations to come. How the world continues to respond to both COVID-19 and HIV will determine if these two pandemics represent a detour in the history of world development, or whether they have major negative economic consequences for the world for generations to come. To put these two pandemics into context, it's useful to look at the magnitude and the speed and spread of each. Since the AIDS pandemic began 40 years ago, there have been approximately 79 million people infected with HIV, while in the last year and a half, there have been 192 million people infected with COVID-19. The number of new COVID infections in 2020, the number of new HIV infections in 2020 was 1.5 million, while 84 million people became infected with COVID-19, a 56-fold difference. In 2020, 680,000 people died of AIDS globally, but 1.9 million people died of COVID, or almost 3 times the number of AIDS deaths. Many of us who've been working for a very long time in HIV recall that it took 4 years to come up with the first HIV test, and it took a total of 14 years before we had an effective treatment for HIV. In contrast, the first treatment for COVID-19 was developed by scientists within 10 months, and a vaccine was produced within 12 months of the first identified case. Clearly, the trajectory of the two pandemics and the way researchers have been able to address them is vastly different. Economically, many countries have been challenged to deal with the massive impact of COVID-19. In the US, the GDP dropped by 33% between April and June of last year, which was the worst quarterly drop ever recorded in the country, including during the Great Depression. The US economy has mostly recovered from this initial shock, shifting from having unemployed workers, a large number of unemployed workers in 2020, to a shortage of workers in many industries in 2021. So far, the US has incurred what economists referred to as a V-shaped recovery. However, given the Delta variants and other variants being faced, there is, of course, no guarantee that this recovery will be sustained. Yet clearly, not all countries are able to recover so quickly, with tourism-reliant economies being particularly hard hit. For these countries, the impact of COVID-19 was felt even before the first cases were reported in country. Of the 15 countries with the worst affected economies in 2020, 6 are in the Caribbean. St. Lucia, St. Kitts and Nevis, Barbados, Antigua, and Bahamas all lost about 1/6 of their economy in 2020. Aruba was the worst hit island in the Caribbean, losing 25% of their GDP in 2020. Now, in terms of household income, the economic consequences are often significant, as demonstrated by data from surveys conducted by Finnmark Trust. In Rwanda, for example, 90% of household respondents interviewed between August and October of 2020 indicated that they had less income than they had at the same time previously in the previous year. This loss of income and loss of mobility associated with lockdowns also has important implications in terms of access to medicines. For example, 32% of households respondents in Zambia indicated that they needed medicines in the last week and were not able to access them. As a UNAIDS report recently emphasized, people living with HIV are at a particularly high risk of getting a severe COVID-19 illness and dying. The COVID pandemic was particularly difficult on HIV interventions such as VMMC, as people were hesitant to become infected with COVID-19 while seeking out circumcision services. According to PEPFAR data, for example, the number of circumcisions performed in 2020 decreased by 17% in Uganda, 30% in Tanzania, 57% in Kenya, 69% in South Africa, and 73% in Lesotho. This drop in circumcisions means that there's been a lost opportunity to invest in a highly cost-effective HIV intervention. It's unclear if this lost opportunity will be temporary or permanent. Meanwhile, COVID-19 has brought to light many of the inequities that exist. If you're an adult living in Zambia, there's a 1 in 10 chance that you're living with HIV and receiving antiretroviral drugs, but only a 1 in 1,000 chance that you're fully vaccinated for COVID-19. In South Africa, there's a 1 in 5 chance that you're living with HIV and receiving ART, but only a 1 in 30 chance that you're fully vaccinated for COVID-19. Even within the Caribbean, there are vast differences between islands. If you live in Turks and Caicos, for example, there's a 57% chance you've been fully vaccinated. But if you live in St. Vincent and the Grenadines, there's only a 9% chance that you've been fully vaccinated.
Stephen, can you wrap up, please?
Yeah, I'm looking forward to the discussions we're going to have today, and just importantly, to the questions that those in the audience raise online. Thank you for joining us, and as always, for being committed to solutions around these critical economic and health issues.
Right, thank you very much, Stephen. You went over time. I'm just going to introduce this for the panel. This is a the equivalent of a yellow card, and it means you've got 1 minute. And this is the equivalent of a red card, and it means shut up. So let's move on to the panelists, because we really are very short of time. We didn't allow a lot of time for this discussion in the hope that people would be able to join it. I am Alan Whiteside. I am the moderator of this. I've worked with so many of you that I'm really not going to spend any more time introducing myself, but I'm going to turn to the panelists now and ask them to each individually introduce themselves, and you have 8 minutes, including the introduction. So over to you, John Stover.
Good day, everybody. This is John Stover. I'm the director of the Center for Modeling and Analysis at Avenir Health, and happy to be here today. My topic is modeling the impact of COVID and HIV. So I want to talk about really 4 different things very quickly. First, at the beginning of the pandemic, the HIV Modeling Consortium brought together 5 different modeling groups, and we all tried to model what we thought were going to be the impacts of COVID on HIV. Now, we'd had no data at that point, so we had to speculate about how the COVID epidemic would affect things, such as closing of facilities or cessation of services, shortage of healthcare workers, overburdening of healthcare staff, etc. So we devised 3 scenarios of 3, 6, and 2-year disruptions in these services of 20, 50, and 70%, and ran analyses for a number of different countries to see what the impact on new infections and AIDS deaths would be like. What we found was that the impact on new infections of short-term disruptions was relatively small, particularly in the short term. And you can imagine for VMMC, for example, the number of VMMCs will be way down. But since most people receiving VMMC are younger and either not sexually active yet or not in their highest risk period, the immediate impact would be small. Although in the longer term, if we miss an opportunity, that could be more important. When we looked at mortality, we found the same thing, except that any disruption in people already on ART losing their access to ART could have a significant impact on mortality. So our recommendation from that work was that programs should focus on maintaining ART services for those already enrolled. And in fact, we've seen that's what's happened. A second activity of the Modeling Consortium was to look at the comparative risks and benefits of maintaining HIV services during the pandemic or cutting back on services. And we did this by using 3 different HIV models, but then also 3 different COVID models. Because what we wanted to look at was what was the potential additional mortality, additional COVID-related deaths associated with COVID infections acquired during travel and accessing HIV services versus the additional HIV deaths that would occur if people did not access those services. And the results were actually quite startling. It suggested that the number of COVID-related deaths would be only 1/100th the number of excess HIV deaths when we did the comparison. In other words, HIV mortality would have been 100 times worse than COVID mortality. So keeping HIV services open was clearly preferred. Part of the reason for that is that we know HIV is a highly fatal disease without treatment, whereas for COVID, it's very dependent on age. And in the age group of people who would be most likely to access HIV services, mortality rates are quite low. And because of the short duration of the disease, prevalence is also low. So based on that, we certainly recommended all efforts to keep services open. Since we did those 2 studies, we've now collected some data. WHO, UNAIDS, and UNICEF have collected data on service disruptions to show us what's actually happened. And what we've seen is that programs have done a pretty good job of keeping people in treatment. They've used a variety of different approaches to make sure that that people don't lose treatment. What we have seen, of course, is fewer people starting treatment, largely because testing has been cut back quite a bit in many countries. and that's led to fewer new HIV positive identifications and therefore fewer people starting treatment. We've also seen some big impacts in other services such as PMTC, but they've rebounded quickly after the initial declines. One thing that in our early work, we also thought that something that might mitigate the impact of reduced services on new infections was there might be less sex and less risky sex going on. And that might be true for some people, but some information being presented at this conference shows that for other people is actually more risky sex, that the economic travails caused by the epidemic have led some young people into selling sex in order to survive and therefore higher risk. And then the last thing I want to mention is for the UNAIDS new strategy, 2021 to 2026 strategy, we looked at what was required to achieve the overall UNAIDS targets of reducing new infections and AIDS deaths by 90% from 2010 to 2030. How is this COVID pandemic affecting that? And we modeled scenarios of 6, 9 months and 2-year disruptions, and basically found that yes, there would be some short-term impact on new infections and AIDS deaths, but assuming that the pandemic does not have major effects beyond 2 years, we could get back on track by 2025 and still achieve the ambitious UNAIDS targets by that year with considerable effort, however, but we could get back on track. The bad news, of course, is that those additional infections and deaths that would happen during this disruption, we could never make up for. So there would be, we estimated an additional 120 to 290,000 new infections and an additional 70,000 to 150,000 AIDS deaths during even a 2-year disruption before we got back on track. So certainly some serious implications, and you're seeing some nice information presented at this conference here also about the impact of COVID among people with HIV, showing much higher mortality rates among people who also have an HIV infection. So I'm going to stop there, and I'll be happy to take any questions later on. Thank you.
Thank you very much for that, John. I'm very happy to hand over to Jeff Sturcio. Jeff, just a quick reminder, you introduce yourself. You have 8 minutes. I will give you this card at 1 minute before the end, and I will give you this card at the end, and you need to stop.
Okay, thanks, Alan. I hope that you won't have to use the yellow and red cards. What I want to do is just talk a little bit about the impact of COVID-19 on HIV/AIDS from the perspective of how the pharmaceutical industry is addressing these challenges. And I'm going to focus mainly on supply chains for the few minutes that I have. Given what Stephen and John had just shared with us, we know that we're only now coming to terms with the scale and scope of disruption that COVID-19 has caused on essential health services around the world, and we're only beginning to understand the associated health effects of those disruptions. The Global Fund did a study of the 5 months between April and September of 2020. They did spot checks of 502 clinical settings in 32 countries and discovered that HIV referrals were down an average of 37%, that HIV testing was down an average of 41%, and that PMTCT services were also down by a significant percentage. So that from the perspective of preventive services alone, there was a major disruption, and this just complements what the information that John had just given us. So let me just, with that as the setting, one of the primary considerations that we have for coming to grips with COVID disruption is the need to protect the supply chain for HIV products. And like many of the products we use in everyday life, and obviously most of our medicines and vaccines, ARVs have complex global supply chains. It's almost never the case that these medicines are made all within one country. API come from China and India. They're shipped to Europe and the United States or Singapore and other places for intermediate manufacturing, and then often shipped somewhere else for the final packaging and distribution. And so these supply chains were affected by the disruption of global transportation networks and global trade patterns that were caused by successive waves of COVID-19 infection around the world. And of course, the pharmaceutical companies, both innovative and generic, had to scramble to ensure that their supply chains would remain intact despite these stressors. It may seem when you just think about what people who are living with HIV do, they have a supply of pills, of capsules, they take them on a daily basis, and that leads to their remaining undetectable, and therefore HIV isn't transmissible. That seems like a simple task, but it is not at all simple to make sure that those supplies of pills and capsules get to the millions of people who need them on a daily basis in more than 100 countries. I mean, just for instance, take the UNAIDS recommendation in response to the COVID pandemic that we should encourage multi-month supplies of ARVs in the ARV programs that people are engaged in. That way people don't have to venture out to the clinic more often, and they won't put themselves at risk of gaining a COVID-19 infection. Well, that decision, which makes perfect sense, has ripple effects throughout the supply chain, because multi-month supplies, in an obvious case, require different size bottles. And if you're going to introduce different size bottles into the supply chain, that needs regulatory review and approval. It needs changes in the final stages of the manufacturing process. It needs changes in storage and delivery requirements, and those adjustments, and also adjustments in the logistics of where the supplies are going to go. So coordinating dozens of decisions like that in a cascade throughout a global supply chain, and coordinating those changes with partners in the health system where these medicines are going to be delivered is, as I suggest, a very complex task. And of course, companies are doing this while their own teams and the healthcare workers who deploy their products to patients are also coping with disruptions caused by COVID-19. So that's just one example of how COVID-19 is affecting the continuous delivery of HIV/AIDS products and by extension HIV/AIDS services. And so the pharmaceutical industry has adapted with agility and flexibility to help ensure that country partners can maintain uninterrupted supply of HIV medicines to the patients who need them. And in addition to supporting country readiness in that way and optimizing production and supply chains, the industry is also contributing in many other ways in the communities where they operate and at the national level, and doing their best to make sure that the therapies that people living with HIV need are continuing to get to where they need to go. And finally, I just think this highlights the importance of the kinds of collaborations and partnerships along the entire value chain that have characterized the way in which HIV/AIDS services have evolved over the last few years. And we're going to continue to need flexibility and agility to make sure that these mechanisms continue to operate so that the disruptions that might otherwise be caused by COVID-19 don't expand further, and that people living with HIV can continue to get the medicines they need. So I'll stop there, and I'm glad to see that Alan didn't have to use the yellow and red cards.
Thank you very much, Jeff, and thank you also for giving me a couple of minutes to play with. We now move on to Shanti Singh Anthony, and I'll invite you to introduce yourself, Shanti, and you have 8 minutes starting now.
Thank you so much. Good morning, everyone. I am Shanti Singh Anthony, the Knowledge Management Coordinator for PANCAP, and I'm representing my director, Dr. Rosamond Adams, this morning. So as you all know, PANCAP was established in 2001 by the Caribbean heads of government with the mandate to coordinate the regional response. This was, of course, at the time when HIV was a serious public health threat. And since then, as the regional coordinating mechanism, PANCAP has delivered regional public goods that have supported and have strengthened national responses and collectively impacted on the HIV epidemic in the region. Over the years, we've made significant investments in building the capacity of national AIDS program managers, in working with civil society organizations to strengthen their advocacy and resource mobilization roles that have really led to robust community responses in reaching the key populations. Central to its role, PANCAP has also been relentless in its own advocacy with the political directorates for legislative and policy reforms to create an enabling environment for all persons to have access to HIV services. Sort of bringing this all together, there has been progress. And the most recent UNAIDS report shows that at the end of 2020, there has been a 28% reduction in new infections from 2010 in the region, and an even more steeper decrease of 51% in AIDS-related deaths. As a region, however, we have not achieved the 90-90-90 global targets, but certainly we can agree that more people know their HIV status, more people are on highly efficacious treatment, and more people are virally suppressed, really resulting in improved quality of life and reduced transmission. Another big area of success for the region has been in EMTCT, and most recently, as you would all know, Dominica was validated, and there are currently other countries preparing for validation and revalidation. Could we have achieved the 90-90-90? Could we have done more? Well, we did operate with challenges. HIV financing is one dimension of the response, but an important one. And in 2018, there were $326 million that was available for the HIV response in the region, but this was considerably less than the $600 million that was required to achieve the fast track targets by 2020. Parallel to the reducing donor funds, which has also fluctuated, there was an increase in the allocation of domestic resources by 69% in a 10-year period. But importantly, while this was 69% increase, this translated to about 27% of HIV funding. How this will change going forward, considering the impact of COVID-19 on the reductions in GDP, as mentioned by our first speaker, we are monitoring to see how this will all evolve. I do believe, though, that we are at a critical juncture of the Caribbean HIV response, where we've made progress, but getting to the last mile will take significant effort. It will require reaching the key populations and their sex partners, who account for more than 2/3 of the new infections, who have the greatest needs, faced high levels of discrimination, and have the least access to services. Reaching these communities will mean definitely redoubling our efforts and resources, and so there's a lot more work ahead of us. And so when the COVID-19 pandemic started in March of last year, our priority at PANCAP really was to safeguard the gains we've made, to ensure that there was continuity in the delivery of prevention, treatment, care, and support services in an environment that was safe and did not put anyone at risk for COVID-19. And so very early on, we conducted a rapid assessment of the situation and found that in many countries, services were interrupted. The assessment showed a multitude of factors associated with the reduced access to services. So, for example, very quickly, the public health measures such as lockdowns and other containment measures, for example, created challenges with transportation to clinics. The HIV programs were affected in different ways. HIV staff were deployed to support contact tracing for COVID-19. Laboratory staff were prioritized for COVID testing. HIV clinics were used for COVID-19 services. Supply chain was interrupted, and many countries were at times with very critically low levels of ARVs and HIV commodities. The main patient-related factor we found was was the fear for COVID-19, and this kept people away from clinics. The impact of this was evident in some countries that have reported reductions, particularly in the second 90, based on the most recent GAM report released earlier this month. Again, PANCAP's focus was to ensure that the gains we've made in the epidemic were not eroded, but that in fact services were being delivered. And so we repositioned our response to take into consideration the COVID-19 pandemic. At the beginning, we supported National AIDS Program and CSOs to understand how best to operate in this new environment, how to repurpose to ensure that service delivery continues, and what new models of care can be adapted. In this regard, we share through webinars, share fairs, and other fora examples of how new innovations were being implemented across the region. Innovations such as the expanded use and scale-up of multi-month prescribing, courier delivery of ARVs, expanded ART pickups that allowed for pickups by family members. And in all of this, we emphasize the message that people living with HIV must be on treatment. And across the region, there was a concerted effort to even track those who were lost to follow up and reinitiate them on treatment. Leveraging the competencies of partner agencies such as PAHO, we were able to address ART supply chain issues and avoid other public health issues associated with stockouts. The pandemic also forced us to accelerate in certain areas where the region was lagging behind. For example, the spotlight was placed on HIV self-testing. In addition to being able to test anonymously in the privacy of one's home and all of the other benefits associated with self-testing, self-testing has now emerged as a tool for testing safely during a pandemic. And so we work with our partners, PAHO, CMLF, and others to advance self-testing in the region. We continued our work with CSOs for continued service delivery at the community levels, including to adopt new technologies to reaching and serving key populations community. These include online appointments, online counseling, and support groups. Our knowledge management approaches were scaled up and clearly demonstrated that knowledge management is an important tool in addressing not HIV in our case, but for health and development. We shared current information with NAP managers and CSOs that ranged from policy and technical documents to communication materials on how to stay safe during COVID-19. We shared policies, guidelines, protocols, research articles, all on HIV, COVID-19, and HIV and COVID-19. We repurposed complex protocols, produced short documents for the partnerships, videos related to COVID-19 protocols, but also on how to access HIV services during COVID-19. More recently, with the availability of vaccines in the region, we supported the overall COVID-19 response in sharing knowledge on the safety and efficacy of the vaccines and addressed vaccine hesitancy. Similarly, we were deliberating our attention to people living with HIV in addressing vaccine hesitancy among that community. Cross-cutting, we were able to reprogram some of our funds.
I have to ask you to wrap up.
So going forward, it would be important to understand the efficacy and the impact of the new approaches, including virtual approaches that I've described, to understand how these new approaches and model of cares will be explored, and where applicable, these should be institutionalized as they have greater potential to enhance quality of care and can lead to significant financial efficiencies once properly implemented. And so in wrapping up, I want to say that we have learned that as a region, we are resilient, we were quick to adapt or willing to learn and share and to support each other, and that while the pandemic has disrupted services, we have persevered, and it is important that we move forward with this strengthened collaborative approach. I thank you.
Thank you very much, Shanti Singh Anthony. That was a very helpful view of where PANCAP is. I'm very happy to now turn the microphone over to Gesine Meyer-Roth. Stephen Forsyth, who is one of the main organizers on this, is frantically messaging me in the background on Skype saying, maybe encourage people to post questions, and I concur with him. It would be nice to have some questions lined up, although we won't take them until the end of the next session. So Gesine, over to you, and you have 8 minutes, starting at 14:37 in my time.
Thank you, Alan. I'm Gesine Meyer-Rath. I work at HERO in Johannesburg. I'm on the faculty of Boston University in the States, but resident here in South Africa. I'm a health economist, infectious disease modeler. I work on both HIV and COVID. And I will try to use 8 minutes, probably 7 minutes, to do some justice to the effects of COVID on HIV and vice versa in Africa, in particular in South Africa, really the only country I can speak about with any authority. So I want to talk about 4 elements in particular, and then there's a curveball thrown in right at the end. The 3 elements are the impact of HIV on COVID in South Africa, the impact of COVID on HIV, in particular budgets and service delivery, and the impact of COVID on the country more broadly. So firstly, in terms of the impact of HIV on COVID, we have seen, and previous speakers have mentioned, the recent WHO review that looked at that found an increased risk for COVID-related mortality amongst people living with HIV, about a third increase. We did similar analysis throughout last year and found that in South Africa, the risk for mortality from COVID was in fact increased by 100%, so almost doubled. The risk was further increased if there was concomitant tuberculosis, in particular current tuberculosis. And interestingly enough, in our analysis from data from the Western Cape, we found no difference of that COVID mortality, whether or not people were on ART or in fact virally suppressed. So HIV does contribute to COVID risk. It is not the largest contributor. We know this. Age and diabetes mellitus, hypertension, etc., are still, and also in South Africa, much higher risk factors for COVID mortality. In terms of the impact of COVID on HIV, that way around, we have seen over the entire last 18 months huge impacts, both in terms of HIV testing, which was in a way all services were taken over, and unfortunately not like what Santi described in an integrated manner, but a lot of community HIV testing teams were basically corralled into the COVID screening and testing response. So testing has taken a huge knock, as have ART initiations, which were down by a third in April to June last year when we had a rather severe lockdown in the country. Similarly, TB symptom screens and tests were down by half during that time period. Both of those have recovered, but we cannot really talk about a V-shaped recovery, neither for the economy, but also not for our HIV services. We've had to push out our national strategic plan, which for HIV, which would have come to an end this year, out by a year, and it is unclear whether we will be able to get back on track in that. Also because our health budget has been equally used for additional COVID services. About $7 billion budgetary support was made available by the government last year for both the health response, but in particular for income protection overall. We've had a 7% reduction in GDP last year. We lost 2 million jobs. In particular, during April and May last year, about a quarter of the population reported acute hunger. These stresses, of course, have been seen the world over, but it does matter if you're starting from a lower baseline. And you will all have seen the pictures of social unrest in South Africa in the last week. There's a number of factors, of course, behind it. You will have seen some analysis of that, but it's undeniable that a large part of it was also due to frustration with the fact that government support for or income provision in the absence of income during the COVID pandemic had ended in April. This was a mere $25 per month. It was extended twice to cover the additional waves of COVID cases, but it came to an end in April, and a lot of people ran out of both patients and means to support themselves, both around about the same time. While we did manage to increase the health budget last year by $1.5 billion in roughly, in order mostly by reprioritizing away from other sources, we had to reduce it by 5 billion, which means that we have less money available for all healthcare, including HIV. This is despite the fact that we have secured enough funding for COVID vaccination. Now, going forward, what we do in a situation like this, we need to stop COVID first. I am, like many of us on the call, and people will know this, I'm an HIV advocate first and foremost. I use health economics to make the case for better and more efficient spending of HIV resources. I am convinced that right now, it does not really matter all that much what the impact of COVID on HIV is. All that matters is that we reduce the impact of COVID on lives the world over. We all know about vaccine inequity. It pains me to the bone for week after week of first the Health Economics Conference, now the HIV conference this week, that we talk about global health as if there was anything to discuss right this minute that's not vaccine inequity. We cannot fix HIV while we are going up and down and up and down, yet another curve, yet another wave of COVID cases, without the protection that the Northern Hemisphere has against hospitalizations and death from these cases. It is, I think, secondary what method we choose to use if we are behind the TRIPS waiver. I think for an HIV crowd, it's really, really an easy case to make, because we know we would never have gotten beyond PMTCT for some children while letting their mothers and then their fathers die, when if we hadn't had a TRIPS waiver for antiretrovirals, which have helped us to save millions of lives over the last 20 years. We need a similar element for COVID vaccination. We also have to increase manufacturing capacity in low and middle income countries in a meaningful way. You might have followed the news where around about a month ago, the US president came out in favor of a TRIPS waiver. Their EU counterparts, and I say this as an EU citizen, in response said they would not get behind it, but they would support a manufacturing plant for COVID vaccinations in South Africa. Well, we have that plant now. It's in Rebecca. It runs at full speed. It produces J&J doses, which, of course, according to what's on the books, go to wherever that needs to be. And the first batches, millions of doses, went all the way back to the EU. So we need manufacturing capacity that's local and that's sustained, that can produce not just the initial vaccines, but the booster doses that will be required for the next years. We know that there can't be any profiteering in a pandemic. We also know that a lot of countries need help with distribution, piggybacked onto extremely effective early infant vaccination programs. Earlier this year, my colleague Linda Gale Becker, and previous president of the International AIDS Society, suggested a PEPFAR for COVID. I do think that is high time. Let me end by saying that we need the same sense of urgency, almost alarm and purpose that we saw in HIV advocacy. But instead of it taking 10 years for us to have an effective intervention, as it was in HIV, and another 7 on top of that for that to be available for all, we need to actually get it done this year. We need all of you in, and that is my last question to the next speakers. As we move to the panel of international institutions and funders, are you in or are you out? Thank you.
Thank you, Gesine. So just to remind everyone, the first speakers, John Stover, Jeff Sturcio, Shanti Singh, and Gesine Meyer-Rath, were talking about what has been the impact of COVID-19 on HIV and AIDS. We move into the second part of the program, which is discussing the financing strategies for mitigating the impact of COVID-19 on HIV and AIDS programs. And we start with a speaker who is incredibly well placed to discuss that, and that is Iris Semini of UNAIDS. And so I'll hand over to Iris now.
Thank you, Alan, and thanks to the organizer for the very interesting session and discussions. I think the speakers before highlighted at length the mutual risk of unequal access to COVID-19 vaccines and the implication for HIV response. And I want to build on what Gesina said. We cannot talk about fully financing an HIV response for an epidemic that there is no cure, there is no vaccine, and it continues to grow unless we address the inequalities that fuel pandemics and epidemics in countries. So what are the financing mitigation strategies on HIV financing? I think I will speak about mitigating strategies for HIV and equitable health and social spending financing, including COVID-19, because those are interrelated. First, for HIV, 40 years in the epidemic, it is not over. We have made great progress, but we can see that systemic issues can really derail our progress. The COVID-19 showed that many countries, I mean, John, I think, was explaining this, had disruption of services, reduced access to testing, reduced access to treatment, which means increasing number of people that will need HIV and AIDS treatment in the future. So increased demand on financing needs for HIV response. So I think one of the first priorities that we have as an international community is to continue to promote, to restore economic growth, particularly for low and middle income countries, addressing the inequalities that are at the corner of the systemic issues that are slowing progress against against COVID-19 and HIV. Just a simple example, we have growth in advanced economics to reach almost 5.4%, which is powered by rapid vaccination and fiscal monetary policies. We go to low and middle income countries, which host the majority of people living with HIV, and we have a spending of average of 10.7% of government revenues on healthcare and 12.2% on debt relief. So these countries not only were unable to allocate the required resources and didn't have the macroeconomic levers that the others had in addressing the COVID-19, but they can also not access COVID-19 vaccines, which makes new variants infections and future funding for HIV response unpredictable. So as we discussed the HIV financing response, we discussed it within a context where the COVID-19 epidemic will make the situation in these countries very risky and unpredictable for HIV financing. The second element that I wanted to bring is that there is a report that was released recently by UNAIDS and Kaiser Family Foundation that found that funding for low and middle income countries reached 8.2 billion in 2020. So there was an increase and progress was very positive. As countries are experiencing the third wave of COVID-19, vaccines are out of reach, then we're going to have an increased number of people who will need funds, but also a limited access to the required services. And this has very important limitation for how much money we'll need for HIV and how we use it. So mitigation strategies that we have been following until now as UNAIDS is first and foremost put up front that inequalities in growth, inequalities in access to treatment, to medication, including to COVID-19 vaccines, and lessons learned from the HIV response are not still shaping the international response to the COVID-19. And unless we address these issues, the money for HIV or the resources for HIV will be always limited and will not meet the needs and demands. The second has been to protect and effectively use the current resources. There is resources from the Global Fund, from PEPFAR, and from other partners. So it's important that these resources are used well in a very effective and efficient manner to reach those who need services. But on the other side, we have seen that the supply chains disruption for HIV prevention commodities and other medicines have been stretched. So even the current use of resources might not lead to the effects that we need. Another element is the UNAIDS has been working with stakeholders in the preparation of the COVID-19 response mechanism put forward by the Global Fund in order to ensure that when countries write the proposal, we avoid to go into a singular vertical way on how we reach those who need services, but we establish mechanisms that reach people for needs related to HIV, for COVID-19 and other public elements. So using the money to deliver more integrated services at the community level has been a priority. Now, where the funds come from, it matters, but also how they're spent requires attention. We need to, what is one of the priorities for the AIDS response in the future, which was highlighted in our strategy and the new global targets that John mentioned, is that the funds need to be used to provide services, particularly HIV prevention services, which is lagging behind, but also to address inequalities, because are the same systemic inequalities that put people at risk or key populations at risk of HIV that also are undermining and underpin the inequalities of the COVID pandemic. And these inequalities are government made, are policy made. We make the inequalities with rules and regulations. So investing the resources not only on program and service delivery, but changing the policies and laws to remove the barriers, it will be beneficial not only for HIV response and but also for COVID. So this is important, making sure that the money goes to reach those who are left behind, like 2/3 of children are not on treatment at the age of 5 to 14 because they cannot be found in the systems that we have, or HIV prevention in Asia Pacific, where mortality rate is declining, but reduction in HIV incidence are slow. The fourth point is to continue to maintain the international funding in countries where the broader macroeconomic resources have reduced countries' ability to increase their domestic contribution to HIV response. So low and middle income countries, not only they don't have the sufficient macroeconomic space to invest on health, but they have an increase on health expenditures because of the COVID needs. They have a shift to other elements of the health response that were not foreseen before, and that further reduces this pressure to increase health spendings, further reduces the ability to maintain the basic services in place. And this is seen also with an increase in mortality, on maternal mortality. The fifth element we want to put forward is that we use this moment of crisis as a moment of opportunity. First, to act to institutionalize and secure funding for the community-led response. I think John was mentioning it, and we have seen that community-led response were among the first, the infrastructure for HIV response, to quickly adapt and use their outreach and their connections and their network to integrate COVID-related services along with HIV prevention and treatment services. And I agree with Gesine, unless we invest in these community-led responses where there is an integrated response to address the COVID in terms of treatment, in terms of prevention, and in terms of vaccine distribution and uptake, along with HIV services, then the money will never be enough to meet our needs. So use the opportunity to institutionalize and fund the community-led response to fill the gaps. The last point is that as we look at how to mitigate or how to secure the funding required to address the epidemics, and particularly HIV epidemic, the HIV community has a strong role to play in promoting transparent and increased equitable investments for health, HIV, and social spending. So unless we learn from the past and unless we promote equal economic growth, where the money then is allocated into health and social spending, there will not be any other resources available to address the HIV epidemic. What do I mean by this? First is to tap into new resources. With the special drawing rights for debt relief, these are money that is being trickled to countries. Past crises have taught us that usually a part of it goes to health and often is linked to austerity measures which undermine equitable health spending and social spending. So being part of the dialogue, of the financing dialogue, and ensuring that there is transparency and equity at the center of tapping in these two new resources is one of the strategies to secure funding for HIV and health. The second is that the health sector can play, the community can play a role in expanding fiscal space, contributing to tax reform and mobilizing and absorbing external financing. But previous crisis has shown that austerity measures start to trickle in, and often once that the health crisis is over, the investments go into other sectors. So continuing to promote and to write a new narrative on making the case not only for HIV investments, but HIV for health investments and increasing social spending, including for HIV, it's a key priority for the AIDS response. So what we need to put forward is to be clear that we need to increase in equality, address the epidemics, but also keep in mind that and keep promoting a clear picture of what is going to happen if we don't address this epidemic and the HIV epidemic. And because it's still a global crisis, it is not over. We have made promise, but it's not over. And every new infection now requires an investment for the next 30 to 40 years in terms of treatment. So these are some of the strategies. First is to make sure that we use the money well.
Iris, I think I must ask you to wrap up very quickly. One last thing.
First, to use the money well, promote increased funding, but not only for HIV, but for health and social spending, in order to promote progress towards UHC. That's the only way that we're going to have sustainable investments. Over.
Thank you very much, Iris. I think the one thing we all need to be aware of is the long-term economic impact of this pandemic, which is immense. And it was brought home to me as I flew back to the United Kingdom from Canada on Sunday evening, just how few planes there were on the runways at major international airports. Unbelievable. This is truly a crisis. And when you think of the peoples whose livelihoods are affected in the developed world, you realize that they have some social support, but in the developing world, it is really a disaster. Let's move on swiftly to Shufang Zhang. And Shufang, I'll ask you to introduce yourself, and you have 8 minutes starting now.
Thank you very much, Alan. Thanks, colleagues, for the opportunity. I'm Shufang Zhang. I'm the Global Fund Senior Advisor on Value for Money, and then of the Global Fund, the newly established Health Financing Department. So for the Global Fund Health Financing Strategy for COVID, I think in a nutshell, it is to mobilize more resources, spend better, but doing so through global partnership and country ownership. So in today's panel, I will just introduce a little bit what Global Fund Planning is doing now in terms of financing, and moving forward, what are the key areas we need to keep pursuing. So what we're doing now, I would also separate our effort at global and country level. At the global level, as you know, in the light of the COVID pandemic, Global Fund has really acted as quickly as we can, and has been very active forming a global alliance to fight COVID transmission and taking new measures which we have never done before to really respond quickly to this devastating pandemic. So at the global level in particular, Global Fund is a core member of the Access to COVID-19 Tools Accelerator called ACT-A to really accelerate the development, production, and equitable access to COVID tests, treatments, and vaccines in order to expedite the end of the acute phase of COVID pandemic. Global Fund co-leads on the diagnostics, therapeutics, and health system pillars of ACT-A, especially around procurement, supply chain, community engagement, and then response aspect of initiative. And then Global Fund has been actively engaging in resource mobilization, particularly for the COVID response. And we made investments for COVID, and we made a pledge through donor community. And then at the country level, our main support I can capitalize in our quickly developed COVID-19 response mechanism, C19RM, and providing resources in phases, being extremely agile, practical, and really adapting our methodology throughout. So in COVID-19 response mechanisms 2020, Global Fund has successfully deployed about $760 million US, especially tapped into the grant flexibility, which is allowed the ongoing country grant to be able to using up to 5% of the savings or from the grant allocation to quickly deploy the resources required for the response. And then in our current response, COVID Response 2021, we also adapted two funding application modalities called Fast Track and Full Funding Request, which is ongoing. And then right now we already approved about another 670 million. And supporting over 105 countries and 14 multi-country programs for COVID response. And we mobilized to date about $3.7 billion with a pledge target of $10 billion. In this COVID-19 response mechanism of 2021, we also provided, in addition to be flexible to have the fast track funding request so that we enable the country quickly fulfill the urgent procurement needs, especially for PPE, diagnostics and therapeutics, including oxygen to save lives. And we will have the full funding request country can submit a little bit later on to articulate better what they want to access resources for. And then for the current round of funding requests, we have also provided very comprehensive guidelines and instructions in terms of what are the key areas Global Fund can support. Those categorized in three major areas, which are deemed critical for COVID response, including for diseases, remedies the negative impact for diseases. This including reinforce the national COVID response and mitigate the service disruption of the three diseases, including HIV/AIDS. The last is to urgent improvement in health system and supporting community systems. All the Global Fund investment translate into purchasing key commodities, raising public awareness, strengthening laboratories, supporting treatment, providing improving supply chain, training health workers, supporting disease programs to deploy and adapt the services, to improve the service access, uptake, and retention, empower community organizations, etc., etc. For HIV in particular, my take is that we have the following characteristic of global support for HIV. COVID response, in the context of COVID response or HIV strengthened response in the COVID context. One is we have really asked countries to sharper the prioritization of prevention, testing, and treatment and care. In particular, we want to ask countries to prioritize those are in greatest need, especially key populations in all locations and HYW and sexual partners in high HIV incidence locations. And there is another character which is very strong adaptation. We did ask countries to think about a permanent adaptation of the service delivery for pandemic resilience, including adopt people-centered models using the pharmacies and alternative delivery channels for services and commodities, especially for testing. There is a much greater emphasis on prioritizing differentiated testing strategies, scaling up self-testing, and especially for the population who are not coming forward, and making sure there is a stronger linkage to ART through different service delivery channels. And we will particularly want country to invest and accelerate the application of digital health to boost the digital health program and digital tools and mobile applications for communication, data visualization, and service delivery, etc. And then lastly, there is also a strong focus on the role of health and the community system. And then we emphasize the support to make sure the supply chain challenges are addressed to secure commodity availability, and then making sure the healthcare workers are protected, and then in also protecting human rights and enhancing community response, etc., etc. So I would just highlight in this funding request, Global Fund also particularly ask countries to articulate their co-financing responsibilities, and then how they think their funding request present very good value for money, including the efficiency and the sustainability, for which we of course want to see countries secure the lowest possible cost for quality health inputs, and then allocate and utilize resources strategically given the country settings, and also ensure the sustainability of their response. So that is what we're doing now. Looking forward, I don't think we're far away from having the job done. We need to really keep pursuing a very solid health financing agenda together with partners. I'll just highlight a few here. Mobilizing, need to continue mobilizing. We're only 37% close to the pledge target we have. We need the more more with domestic and other funder, development partners from the financing. We also want to catalyze our investments through joint blended financing. I think this requires better coordination with other financing institutions to think about how do we bring our money together. Ideally have a common vision what should be supported and make sure there is no duplication of the country request, and then we drive a much more sustainable investment at the country level. So we would like to do this with development partners, of course USG and bank, GFF, Gavi, and other regional development banks for joint blended finance. And then we also, I also want to echo the importance Iris mentioned about the efficiency of the investment in COVID-19 response. I think it's both for COVID-19, but not in isolation for HIV and other 3 diseases. I very much agree about the service integration, and I also think we need much better data to inform strategic investment decisions, to better inform, for example, resource needs and then the cost of service delivery in the era of pandemic. I would believe the cost structure of the HIV or other services are changing in the context of COVID. In the past, we don't need PPEs, we don't need, you know, maybe much more door-to-door service and etc. So that will add a cost. I guess we don't have a lot of understanding what is the future cost would be, and this is a task I think for the colleagues on this webinar and others to think about understanding the change of the cost so that we can better understanding even the cost effectiveness of the different service modalities or mitigation modalities for service delivery, as well as the direct COVID investment itself. And then the one more point is that we need to continue strengthen the public financial management along the line of budget formulation, execution, and monitoring, including good resource tracking. A lot of our COVID resources was channeled in a very fast manner, and we also allow the potential flexibility in other settings may not be required absolutely you know, very strong financial control measures in the settings. There are some settings, but we need to think about tracking them. Lastly, is to ensure the sustainability of the COVID-19 investment, especially for the concurrent cost and capital investment. What is going to happen after COVID or for general pandemic premise? How can we ensure the COVID investment is sustainable? So over, thank you.
Thank you very much, Shufang. Much to think about there, and I'm happy now to hand the mic to Mike. The mic to Mike.
Great. Thanks, Alan. Appreciate the invite. So if I could just kind of knit together what I've heard and reflect on how the PEPFAR program. So first, we've heard a lot of worry, and certainly the PEPFAR program has worried. We worry quite literally, formally, every day and now every week. We started off the pandemic sending out guidance on adaptations on the ways the program should work, and we continue to put out new guidance every week. But we've also heard that supply chain systems have adapted. We've had a lot of adaptations in our service delivery, particularly for treatment. We achieved in 2 months what we've been beating our heads against the wall for several years when we convinced everybody they should go to multi-month dispensing. And so we've been able to have considerable of efficiencies there. In fact, a lot of what is formally coming off as the COVID response is actually piggybacking on basic domestic investments, basic investments by the Global Fund, and basic investments by the PEPFAR program. When you look at our structure of spending, you realize that outside of the commodities, most of our spending is sticky, and most of that is on personnel. And so as we've been decongesting clinics, we've been freeing up resources to go into other things. And so clearly there's also a lot of worry about prevention, but for the short term, we don't think that there's been really major deficits that have come from that. And so if we look at this all together, the PEPFAR program has actually seen continued positive results, positive growth in what we see as our program mandate. Now, I think the issue, though, is that this was fine for a year. We were able to adapt. I think our worry is that we're getting a little bit too complacent in potentially in the HIV program or within the PEPFAR program, that we've been able to withstand this. And I think that the next couple of years, because of the inequities around vaccines, are going to be potentially much different for the HIV response. And we'll just take the case of healthcare workers. Already there's not enough. And we know that the epidemic, the COVID epidemic is really setting its sights on those frontline workers, both at the facility and the community level. And while we can lose people to death and walking away from it, that will be exponential over time if that accelerates. And so we really have to keep an eye on that, because you know, the healthcare workforce is something that could potentially be a long-term problem. So in any event, as I said, we've seen positive growth, albeit at a slightly lower slope than what we were wanting to do. But the innovations in testing, yes, we haven't tested as much, but we are already trying to test less. We are trying to test smarter. We had already been trying to push self-testing as the way that people will find their status in the future. So we've really kind of accelerated a lot of things that we wanted to do. I think our biggest question, though, is what's going to happen to partner government financing over time. That's, to me, should be one of our real concerns. Right now, we undervalue and underappreciate what domestic governments do. We don't always see a dollar tagged to HIV, and when we do, and you compare it to what the PEPFAR and the Global Fund can do, they seem out of sorts. They're just not in the same magnitude. But that spending by domestic governments on the basic clinics, on the personnel, all of those things that we piggyback are enormously important. And if those are under threat over time, that's going to have a huge effect on our program. That said, though, I think that there's still a lot that we can do within the PEPFAR program to become more efficient, and that's where we're going. I think that there's a lot more bang for the buck that we can get out. As I said, as the structure of our spending, we don't have a lot of variable costs outside of commodities. And when we look at what we do spend on personnel, a lot of that goes to activities that are not done at the site level, that are not part of the actual connection to the patient. And even those things that are done at the site level, again, in an integrated care setting, we're buying a lot of other health outcomes in addition to the HIV outcome. So there are a lot of things that we can do to weather over the short term some of the challenges. Of course, our question really becomes, in the long term, can we make up the ground quick enough that we've modestly lost over the last year, and may lose more over the next couple of years, by the time that the donor community wants to scale down. We're already starting to see other countries scaling back, and I think that we've solidified investments in PEPFAR for a few more years, but even there we'll have to be looking at that. So that shift to local responsibility, how do we integrate better? How do governments, at a time that their funding is going to be constrained, how do we put all of those together? So I think those are the big challenges that the PEPFAR program faces. So I won't go on too much from there. I'll probably give back a few minutes, and I'm really happy to answer questions as they may be. But as I said, I think the bottom line from us is that we've adapted, we've had forward progress. we're still where we've achieved epidemic control in the Lesotho's of the world, we've been able to maintain it. We have a large question mark around prevention, but I think that's something that will compound over time. And so the longer that this goes, the worse it will be. The inequities that we see, the problems with stigma and discrimination are things that we were fighting before and will continue to fight in the future. And if anything, it's just shown a light on why these are so important. And that may be a small side benefit to a lot of the devastation that we've seen. So with that, thank you, and I hand back over to Alan.
Thank you, Mike. Let me foreshadow a question that is going to be posed to you, and that is, how do we ensure that the funding is spent efficiently and legally, and that the Office of the Auditor General will accept the way we're doing it? And I speak having been burned on the AIDS front with this regard to this. So that's something for you to ponder, and then we'll come back to that in the question time. Timothy, do you want to briefly tell people how to pose questions? Timothy?
Okay, yes, everyone, it's the questions tab on your GoToWebinar control panel. You just need to click there. I think it's below the handouts tab. So you go to your GoToWebinar control panel and it's the questions tab. You can also, there's also a chat tab. You can also post your questions there and we'll be able to see them.
And I am seeing questions, so I am certain we will not be sitting here looking at each other with no questions to answer. So let me move now on to Greg Parent. Greg, introduce yourself, and you have 8 minutes starting now. Greg, are you able to join us? Timothy, we're not getting Greg on the line. Greg, I'm going to put you on hold, and hopefully you and Timothy can sort it out, and I'll ask David Wilson to go next. David, I'm going to hand the mic to you now to give what may be the last presentation, but I sincerely hope not. Greg, David, you're muted. David is muted. Timothy, can you unmute David?
I think I'm unmuted.
You are
Brilliant.
unmuted.
Thanks for your patience, everybody. Thank you. We can't return aid services to normal until we've controlled COVID. And as Justine and others have noted, we can't control COVID without equal global vaccine access, which is why the World Bank has increased its vaccine financing to 20 billion. And we're proud to confirm our partnership with the African Union Vaccine Acquisition Task Force, which includes CARICOM, and our commitment to finance all the purchases the task force makes. We're also pleased to confirm this week our pre-financing guarantees for COVAX. With this critical proviso, let me start with the clearest opportunities, graduating progressively to the challenges. I think we'd all agree, the most obvious unintended boon of this pandemic is the fact that we've compressed a decade of progress in the life sciences into a year, and can expect further blinding progress as the impact of mRNA technology, for example, expands into vaccine development for HIV. And I think the clear implication for the HIV response is that biomedical responses will continue to be prioritized over social links. And I do think we have to use the very real allure of new technologies and the promise of an earlier end to the pandemic to sustain HIV investments. Today, long-acting ARVs, for example, tomorrow, vaccines. Second, the other clear boon of this epidemic is that it's accelerated telemedicine, remote medicine, digital prescriptions, multi-month dispensing by a decade, and regulations enabling telemedicine that couldn't be approved for years were approved in an afternoon when COVID struck. And we have to harness this progress for HIV and other health challenges. I think a possible boon of this pandemic, if we can reap it, is increased ambition in public health approaches. Better diagnostics, screening, linkage to care, contact tracing, and expanded vaccination and treatment. This won't happen automatically, but just think of the advances in the management of HIV and other communicable and indeed non-communicable diseases if we can approach the level of ambition achieved for COVID. And an opportunity, but arising from a stark challenge. COVID has increased inequality as lower income communities were unable to shield and bore the brunt of this pandemic and lost livelihoods through it, while the affluent sheltered and grew their assets. And as this becomes even clearer, it may create renewed opportunities to address inequalities to improve health. This won't happen of its own accord, but we can work concertedly to make it more likely. Now quickly to the clear challenges. It seems clear that HIV will be one of many contesting priorities in a post-COVID world, and we've got to adopt our advocacy. We simply cannot put the toothpaste back into the 2019 tube. Overall health and development assistance are likely to decline, if only because economies may be smaller, as Mike and others have noted, and health and development assistance financing is likely to prioritize health security. We have to do our best to make sure these health security investments are channeled into health systems to strengthen primary health care, including HIV, so they don't cannibalize existing health spending and aid. Single disease advocacy is unlikely to be persuasive, except for issues as compelling as COVID. Not only do finance ministers not think in terms of single diseases unless they become pandemics like COVID, but they also tend to think of health, education, and social protection as one cluster, the social cluster. And we have to join forces with other health, education, and social protection advocates to argue for investments in human capital, in healthy, skilled, productive, and protected human resources. And I think that concerted advocacy for human capital investment will be vital during the next two economic phases before us. During the coming cycle of reflation, we are seeing that governments are prioritizing economic spending to restore jobs and growth as quickly as possible, and human capital investments may be neglected. And during the following phase of budget repair, human capital investments will also be squeezed on the downside. And it's clear to me that HIV financing will need to be better integrated into domestic budgets, which Mike has described as being under threat, and into expanding UHC and health benefits packages. And HIV service delivery has to be better integrated into primary healthcare, the capstone of UHC. And our advocacy has to be better integrated across health, education, and social protection. The era of single disease advocacy is truly over, and we have to ensure that the world understands how much human capital scarring COVID has caused and how central human capital investments are to robust, renewed growth. Thank you.
So much, David, for that very important intervention and also very timely intervention, which is just as well because we have another speaker whose name had slid off the list, and that is Susanna Barker. But I'm going to go to Greg Parent first, and then we'll come to Susanna.
Hi, thank you. I had to be unmuted by somebody else. I'm Gregory Parent. I'm a senior economist and current acting branch chief for the Economics and Health Services Research Branch at CDC. I come by way actually of the resource economics field where my PhD derives from, but it's been in public health and CDC now for about 9 years. Mike touched on several of the aspects that I was going to touch, so I will be brief. So certainly in terms of some direct additional financing, there has been some PEPFAR funds that have been deployed with the goal of either minimizing COVID-19 on HIV positive individuals or on the staff that supports HIV programs. Going into FY22, which will be starting shortly, there will be a portion of the ARPA funds made available to minimize the impact on COVID-19 HIV programs. That's going to be deployed through pretty much most countries that are receiving PEPFAR funding. But I'd say that the groundwork that we see that has minimized the impact of COVID-19 on HIV programs had started to be laid years ago via PEPFAR investments and priorities in activities. First, for getting there, we have seen, and this has already been mentioned by several speakers, a differential impact across HIV programs. While some areas such as VMMC, as Stephen mentioned previously, and certainly a reduction in some testing numbers, as well as other prevention-oriented activities in many countries, the impact on HIV care and treatment services has been largely minimized. PEPFAR over the last several years has been promoting and funding changes to care and treatment service delivery. This includes the move to community-based care and treatment options, in addition to multi-month dispensing, also mentioned by Michael and others. The goal at the time for this strategy was to decongest clinics and to free up clinical staff for additional patients or services. Further, they were focused to be more patient-centered. However, having these processes in place in many countries ahead of COVID-19, and certainly during COVID-19, reduced the impact to some of our direct care and treatment activities, which we've seen in our numbers across PEPFAR. Increased decentralization of service delivery and ARV distribution combined with MMD reduced the need for travel to clinics and pharmacies, which is largely done via public transit in most countries, and also exposure while at the clinic. And further ensure that interruptions to treatment were minimized in countries where MMD was in place. And we're seeing in many countries, MMD is either at 3 and in some countries at 6 months. At this point, we should expect COVID-19 will be with us for quite some time and should be looking further at innovations to other program areas such as VMMC, such as testing, where we have seen an increased movement towards self-testing, and also prevention activities to minimize the disruption to service delivery from expected future COVID-19 impacts. As we saw in the West Africa Ebola outbreak several years ago, and now with COVID-19, PEPFAR investments in HRH, laboratory, and systems proved to be extremely beneficial in helping countries monitor the spread and prevent treatment for related illnesses. For example, countries have leveraged investments in HRH systems to understand the impact of COVID-19 on healthcare workers, to ensure the impact was mitigated, and to inform vaccine rollout to critical HRH staff. In fact, an example from South Africa, PEPFAR helped to develop improvements to the HRIS system, ensuring different HRH systems were interoperable. The MOH used this and is expanding on the HRIS to help with planning and allocation of healthcare workers for the vaccine rollout and for COVID response in general. We have had many other countries leveraging HIV investments in laboratory equipment, capacity, and system to assist in COVID-19 testing. In addition to seeing benefits from surveillance and other data systems investments, with countries able to leverage these systems and capacity to monitor and track COVID-19. Jacine makes a great point. The best way to mitigate the impact of COVID-19 on HIV service delivery is to reduce the future spread of COVID. Part of this is certainly to maximize pre-existing resources to address this pandemic. Moving forward, it would be interesting to see how investments in, say, unique identifiers that has been done in the HIV space can be further used to improve vaccine rollout and coverage and monitor elements of equity. And I'll certainly end at this. David touched on this. We've certainly seen that a common theme at IAS this year has been integrated care. Without a doubt, this can lead to a more efficient use of resources in health, but it has to be a smart integration with incremental expansion of scope, focusing on service delivery design that addresses patient needs to maximize demand. We continue to see how investments in HIV driven by PEPFAR and Global Fund has had broader health systems impact. Understanding how to broaden these linkages would both improve the potential long-term sustainability of HIV financing while minimizing the impacts of future pandemics via a broader health system capacity building. Over.
Thank you so much. And now we have Susanna Barker. I do apologize, Susanna, for not having announced you earlier. I am going to blame Stephen and Roger for sending me not the correct program, but I also have to take responsibility for that. But it is a real pleasure to have you here. Please introduce yourself and try to keep it within 8 minutes if you can.
Great, thank you so much. And no problem leaving me off. At least I managed to make it in. So as the moderator said, as Alan said, I'm Susanna Baker, and I lead the Health, Finance, and Economics branch at USAID. So in this role, I managed over the past 3.5 years the Sustainable Financing Initiative, which used PEPFAR resources, almost $48 million in PEPFAR resources in 16 countries and 2 regional programs. And we worked on increasing domestic financing and improving sustainability of the HIV/AIDS response. And so I feel like these lessons are even more important as the world grapples with COVID-19. So I'll reference that program as I go through my remarks. I wanted to speak briefly, a lot of people have spoken on this, so I'll just briefly touch on the overall financing situation for HIV/AIDS and then conclude with what we know about the commitment by the Biden administration for COVID-19 and HIV/AIDS. So Iris had mentioned the latest Kaiser Family Foundation and UNAIDS report released this year, but I just wanted to highlight a few other data points from that report. So we saw that overall donor government funding for HIV increased in 2020, but this was mainly due to the US contribution to the Global Fund due to prior year commitments. So bilateral funding from most donor governments other than the US declined in 2020, and PEPFAR has basically flatlined spending on HIV/AIDS. So we see that the US portion of funding increased from 54% to 76% of total government HIV spending, and we all know the results have been remarkable with over 20 million lives saved. So the future of HIV funding needs and funding availability is still not clear. I think that's what the data is showing us. Global economies have clearly not recovered to pre-pandemic projections, and we have the ongoing third wave of COVID and limited vaccine availability in many countries. So I think all of this calls into question how the recovery will proceed. So what can we do for financing of HIV/AIDS in the face of this uncertainty? So I wanted to call on a few lessons from the Sustainable Financing Initiative to maybe provide a way forward on how we could address this. So while we focused on increasing domestic contributions under the Sustainable Financing Initiative, you know, in the face of these budgetary constraints we're seeing, we understand that countries will probably not be able to increase their overall contributions to HIV, and we need to look at other solutions such as increasing efficiencies of the HIV response, expanding access of care in the private sector, and integrating HIV care into the broader health system. So under SFI, one of the areas we focused on was public financial management, or using existing funds more effectively. And so we saw results such as in Uganda, through better financial planning and oversight, the percentage of budgets dispersed rose from 80% to 97%, and this resulted in an increase of health spending of 17.4 million over 2 years. So even though the overall allocation of resources didn't increase, the better use of these funds resulted in an additional amount of funding available for health. So I think this points to one way we could look at efficiency. In our second area, in the private sector work, we focused on inclusion of the private sector into the HIV response. And one of the most successful interventions that a number of panelists have mentioned was the decentralized drug distribution, where ARVs were decanted to pickup points in the private sector, such as private pharmacies, clinics, or e-lockers, and this was more convenient for the patient. It became especially important in light of COVID-19, where it helped to decongest public facilities, ensure continuity of care, and it reduced the exposure of staff and HIV clients in healthcare settings that may be overburdened or sources for potential exposure. So through this funding that we used, at least 19 PEPFAR countries are implementing decentralized drug distribution. 17 countries are distributing through private pharmacies and clinics. And just to point out one specific example, in Nigeria, 14,000 clients are now accessing ARV refills in private pharmacies with a 97% retention rate compared to 74% in the public sector. So we see that it can work, and it's in many cases shows clients show a preference for more convenient pickup points. And then the final area of intervention that I wanted to point to as perhaps having lessons for financing in light of COVID-19 is the integration of HIV into the broader health system, or conversely using the PEPFAR platform to provide care for other diseases. So the PEPFAR COVID-19 guidance calls on us to leverage PEPFAR supported health systems and infrastructure. And we know that countries need to fund entire health systems and not specific diseases. And so while we must spend our funding as mandated by Congress, our work has helped integrate HIV into existing health platforms such as national health insurance programs. So for example, in Vietnam, our work helped the government expand social health insurance coverage for HIV services, and it integrated outpatient facilities into the public health system. As a result, 90% of people living with HIV/AIDS were enrolled in the social health insurance program, and over 45,000 people obtained their ARVs through the program. So I think these lessons, show potential ways forward in light of COVID-19. And while our attention is focused on COVID-19, we cannot let our attention waver from continuing the HIV/AIDS fight. 6 countries are currently at or near epidemic control, and we need to continue to fund HIV to maintain this momentum and move other countries closer to epidemic control. The Biden administration recognizes this, and through the American Rescue Plan has allocated nearly $11 billion, which is approximately 5% of the total ARPA funding, or the American Rescue Plan funding, to USAID and the Department of State to fight COVID-19 pandemic. And among other things, it specifies that this funding should mitigate impacts on HIV/AIDS as well as TB and malaria. So the guidance also calls on us to strengthen health systems and develop coordinated responses to infectious disease threats. There's language around developing a sustainable catalytic global health security financing mechanism, and I think we're all eager to hear how that will take shape as it moves forward and we get more details. And so this plan and this call for action from the administration is in line with how we have been trying to leverage efficiencies, engage the private sector, and integrate HIV into national health systems. So we can only hope that these gains continue and accelerate as we grapple with COVID-19. So thank you, and look forward to the questions.
Good. Thank you very much, Susanna. That was most interesting and helpful. I'm just going to put in one word. I think what the American government under the new administration is doing is quite remarkable. I wish I could say the same for the British, who are not. Britain made a commitment that it would give 0.7% of GDP in overseas development assistance. And so Britain's overseas development assistance is declining rapidly as a result partly of COVID, but also of Brexit, which is terribly sad indeed. So let's now move to the questions. And I would like Mike and Susanna and perhaps even David to reflect on how are we going to ensure efficient, but perhaps more importantly, legal rapid spending that won't result in auditors coming in and trying to shutting programs down. So Mike, Susanna, whoever wants to take it.
Can you just expound a little bit more on the issue about legal? So you're saying rapid spending, getting it out quickly, and my question is what rapid spending that would have to go outside of normal processes do you see necessary?
Well, I can just talk from what we experienced with our organization in Durban, where we were told to expand things rapidly and then got into trouble for putting people on airplanes where the code share was SAA stroke United Airlines, not the other way around. There are rule books, Mike, rule books, and we won't have time to go through them.
Yeah, no,
The point isn't at the delivery of the USA. The point is that you have an Office of the Auditor General who will come in and say, well, you broke the rules.
It is absolutely true that the U.S. government has massive volumes that of rules that trip people up all the time. In the end, I think so far we've been able to manage the adaptations. I think one of the things that's going on right now with the PEPFAR program is that we haven't really talked about the spillover benefits of the types of things that we invest in. Legally, everything is supposed to have an HIV purpose. But clearly, when you invest, there are lots of other side benefits that come to that. And I think that we're kind of reaping the benefits of that. This point about rapid spending, of doing things quickly and then potentially running afoul of rules. I don't really know how to answer that other than to say that if we have good contract administrators, that those who are executing the program should not be able to run afoul of the rules. And it's really on the PEPFAR administrator standpoint to be able to make sure that the funding goes out legally. So as I said, I think that so far with our rapid adaptations of what we've told our implementing partners to do quickly, very quickly, has all been within the spirit and letter of the law. There's just an underlying, there's just an underlying problem that sometimes spending goes out, even in the best of times, that's not in complete accordance with that. And that's just not going to change within that. And so, as I said, I think that we've been able to rapidly adapt without too many of these problems. Maybe Susanna has a view from.
I'm going to go to Susanna, and then I'm going to go to David on this one. So Susanna, your comments, please.
Okay, I was hoping Mike would take it for the U.S. government perspective, but maybe the only thing I can add there is, under the Sustainable Financing Initiative, which we did over the past number of years that I've been talking about, there we are working on financing, and there was always this tension between, we receive HIV funding, it has to be spent on HIV, but how do you work on financing of a health system when you're working on one specific disease? And so I think this is a tension we've had to grapple with in terms of, all of our funding has to start with the lens of, we're working on HIV, and then to Mike's point, the spillover effects. How do we integrate HIV into a national health system? So really being creative in terms of all of our funding does have to speak to increasing or improving the HIV response, but being creative with what that ultimately means at the end of the day and staying within the letter of the law. So something we've had to grapple with as well. But I think there is a way to leverage the kind of spillover effects of HIV funding and financing to benefit the broader health system, especially, they're both pandemics or epidemics. And so how do you leverage the PEPFAR built infrastructure, which is quite robust in most countries, to then, have the COVID response go out through that. So that's maybe all I have. I have no great solutions, but I'll let David perhaps propose his.
Alan, if I could interject on the USG side of things, part of the strategy that PEPFAR is using to rapidly distribute, especially some of the ARPA specific funds and other related COVID-19, is leveraging, as kind of Suzanne touched on, our pre-existing partner infrastructure. So much of the funding in PEPFAR goes via either USAID or CDC. We have a very robust kind of grants and management process in place. So we're not trying to quickly identify new partners who may not be familiar with government systems. We are leveraging partners who have received PEPFAR funds and are used to operating within this environment. So that's part of our kind of accountability and management strategy for the rapid distribution of funding. Over.
Okay, thank you. David?
I'm the last person to talk about USG procurement, but I just will say that the last 18 months of COVID-related procurement have been the most difficult we've ever faced because of the sheer number of predatory intermediaries, initially for things like PPE, ventilators and oxygen, and now for vaccines. And I can't even begin to describe the number of predatory intermediary contracts that we sift through every day. So far, I think we've managed to keep on top of them, but it's a tricky field. And then, Alan, just to contextualize the US-UK development assistance discussion, it is worth noting the US's development assistance is 0.17%, and the UK's, even after the decline, is 3 times higher at 0.5%. So, just to keep that in mind too. Over.
Thank you, David. I'm not going to let the UK government off the hook because it's not what they promised, and that's, to my mind, is the problem with them and the way they're finagling. Yeah. Any other comments from anybody else before I go on to the next question? Nope. Okay, so then the question that I have now is that one of the questions that has been posed is HIV off the map? And Iris, maybe you can just pick up that and say, honestly, from your heart, do you think that HIV will slide off the map for a while?
So I don't think it's off the map. We did have a very broad and participatory high-level meeting where the commitment to HIV was renewed by all government and partners and UN, and the panels were well attended and many participated. We have a new global AIDS strategy which was developed through a very wide participatory approach. Contrary to the past, it's not only for the UN, but it's for the AIDS strategy. And we have a very strong voice from the community organizations who are relentlessly raising the issues of not allowing HIV to fall off the map. But this is when you are within the HIV community, right? Once that you step out of it, there is the risk and there is the attention going to other issues. Now, going to COVID is legitimate attention. What we are trying to push is that you need to control COVID, but you cannot not control HIV epidemic, because the impact will be more negative if you focus on one epidemic. That's why the thinking of speaking about HIV and progressing to control the HIV epidemic in an integrated manner. So I think the new element that is coming up with the COVID response, it was mentioned where the community response, the HIV response was used and built on the platforms that existed to reach COVID out. Where we think that there is a risk of HIV falling off the map is when the policy decisions and the funding and financing decisions are made. Because there is also this sort of misunderstanding that the HIV epidemic is over, it was well funded, is well managed, so now we can move on to something else. But we are not there because it cannot be over without cure, without a treatment, without a vaccine. And I want to link this with the previous point of the USG government using HIV money for financing. You cannot think of HIV financing in the long run without having strong systems, health financing system and social spending systems in the countries. So it's a legitimate reason to build on the HIV sustainable financing argument as an entry point to build systems that uphold the right to health of people living with HIV and key populations. Otherwise, even if domestic funding is put on these programs, if you don't have systems that reach sex workers or that remove barriers, the epidemic will return. So I think it's a dual shared mutual beneficial platform that we need to build with the health and social spending. It is risky, but what we are worried that it might fall off the map is by this misconception that the HIV epidemic is over. We can manage. And we forget that, as I said, one new infection needs another 30 to 40 years of treatment budget. So it's a bit of a half full, a half empty, I would say.
Thank you. Gesine, I'm going to come to you now. We've watched with horror as KwaZulu-Natal, damn Jacob Zuma, and parts of Gauteng have exploded over the last few weeks. We also are aware, well, no, not everybody's aware of it. I'm acutely aware of the fact that Swaziland is in a terrible, terrible mess and is probably even more unruly than South Africa. So, Gesine, do you think that HIV and COVID have played a role in causing the civil unrest in these countries? And how do you think we'll be able to manage both those pandemics in the context of the civil unrest that we're seeing? And sorry, Gesine, you're not a political scientist, I know.
I'll give it a best. I don't think that HIV played a role. Let me put that front and center. Eswatini, as we know, is one of the few countries in the world that has actually reached their 90 targets and has done a sterling job of that. Despite the current government is a completely different discussion. South Africa is doing well on the first and third, is lagging really on the third 90. But I don't think this is exactly the stuff that fuels social unrest as it would have, and as it did, of course, kind of 10, 15 years ago. What I think is important is that COVID absolutely did play a role, and I tried to make that link earlier on, where basically the readiness for quite a sizable part of the population to get onto the bandwagon and essentially loot for food was quite clearly fueled by the fact that people have been hungry for 1.5 years. And I don't like talking about food insecurity. People are hungry. And we were very much aware that this whole situation with restrictions, etc., and the economic impact that we've seen would create this kind of powder keg that's now gone up in flames. 10 days later, it all looks a lot quieter again. But this does not take away from the fact that people have run out of patience and are in a very bad state, which is why I keep coming back to this theme of, our HIV investments are under threat immediately if we can't figure out a way of getting everyone vaccinated really quickly. And I just want to add to that South Africa is in a very unusual situation in that we are in a position to fund our own vaccines. We are still, money in hand, joining the queue very much at the back when it comes to negotiating with manufacturers. Right now, we don't know if we'll have doses beyond the middle of August, which is no situation to actually plan a mass rollout. Those are the elements that we need to collectively work on. And as I said, this is of immediate concern. I completely agree that we've made a lot of strides in the last year, completely despite ourselves, in integrating services and including more communities, in making multi-month dispensing work. Who knew that people could actually, live off 6-month scripts and do this responsibly? All of that has helped, but it's really, really marginal. We need not kid ourselves. We cannot get on top of HIV services and progress there. We'll see many, many more lives lost if we don't get around to vaccinating everyone at the same time. Last thing I'll say on that, I think almost more dangerous than not vaccinating is just vaccinating only half of the population, or the COVAX approach to 20%, and that's healthcare workers. I do, from all the, watching the variants of concern emerge, all that work, I have a strong feeling that we will see new variants emerge that will have been selected for resistance to vaccines if we only go halfway. We either go the whole hog everywhere in the world all at the same time, or we let it be.
Alan, can I come in quickly to support Jacine here?
Please.
I just wanted to say that just as I think we underestimated the scarring from the Great Recession of 2007, we've completely underestimated the depth of the scarring that will result from COVID. And one of the big threats to HIV and health recovery is going to be political instability, not just in South Africa, but in many, many places. So increased political instability has to be the base case for the post-COVID world. And that's really difficult. And just to endorse everything Jacine said, and just to say how much I admire South Africa's COVID response built on its HIV response, but also just to take every chance to say, I think it's a pity South Africa did give away the 5 million AstraZeneca vaccines for a host of reasons, including its contribution to reduced AstraZeneca acceptance globally. But that's not to detract from an awesome South African response. Thank you.
The response that has been even more awesome is the one from the UK government. What a pity we have such crappy little paper cards. Right, John, I see you're laughing. You appreciated that. We do need to move to closure now, and that means that we must give Akola Lewis Cameron a chance to say goodbye because she wasn't able to say hello to us. So if she's on the line, could you please join us? Otherwise, I'm going to ask Roger to step in and do the closing remarks and the next steps. And just to remind everyone, this panel has been brought to you with a very hard work of the International AIDS Economics Network. I think we've done a remarkably good job, even though I say so myself. And I think we must try and do this again and perhaps make it more broadly available. This has worked for us, and congratulations particularly to Stephen Forsyth and Roger McLean, who've done the heavy lifting. I've just sat in the background and grown my beard. Roger, over to you and to Akola Lewis Cameron.
Thank you, Alan. And I'm speaking on behalf of the Dean of the Faculty of Social Sciences, who unfortunately had to step away. And so firstly, to bring greetings on her behalf and thank the participants as well. We really need to thank the persons who really contributed tremendously to the success of this event. John, Jeff, Shanti, Cassine, Iris, Shufang, Mike, Greg, and David. This is, you've contributed towards making
and
this
Susanna.
very, and Susanna, sorry, and Susanna, I have Susanna, my apologies, sorry, and Susanna, it's very rich exchange. And when we sat a few months ago, and literally a few months ago, and started thinking this through, and we felt that we needed to provide a forum to exchange on what has been happening, the impact of COVID-19 on the HIV response and broader health issues, and as well to look at what are the issues around the sustainability of the response and how we can look at it through the financing lens, look at the financing models, and how has these models been applied to, and the extent to which they have had an impact to maximize the way in which we respond or continue to sustain the response of HIV within the context of the COVID-19 pandemic. And then to look at, coming out of the discussion, where are the gaps, what are the things that we still need to interrogate further, what are the research agendas, and what are the information needs that we need to speak to. So this was really the basis for bringing you together and convening this team of the wealth of experience and knowledge that we've been able to see here today. There's some critical issues that have emerged: the issue of the integrated response, and the need to some level of preparedness on the part of both the countries and the agencies. Efficiency measurements, among others, came up. And so what we've seen here, and one of the things that we've earmarked for in terms of where we see this going forward, we saw this and we see this as one of a series of webinars which will culminate in the International AIDS Conference in 2022. And so this is one of a number of similar webinars that we plan to embark on. So we will be continuing the conversation, building on the issues that were raised, some excellent points that were raised, and there is an opportunity for further discussion as we bring new folks back to the table. And please welcome the persons who have, the ones who have attended, and the presenters continue to engage with us, because we will continue this dialogue as we move forward to the next webinar. So finally, I'd like to thank the participants for staying the course and contributing rich questions to the webinar. To my colleagues at the Pan-Caribbean Partnership, who facilitated the effort through the provision of the GoToWebinar platform. To my colleagues Alan and Stephen, we continue to sit and exchange and come up with these ideas in terms of how we can continue to provide this platform for continued engagement, and working with the IAEN in this effort. The University of the West Indies is tremendously thankful for the collaboration that was made possible through this effort. And so before I turn over to Charmaine to close us off and send us off, I want to once again thank big heartfelt thanks to all the presenters. It has been a tremendous effort, and the exchange has been rich. A number of my colleagues messaged me quite, privately and said, can we just continue? They just didn't want to stop, But so this speaks volumes to the success of the event. And so once again, a big thank you for taking the time from your very heavy schedules. And we look forward to engaging with you in the webinars to follow. Thank you. Charmaine, over to you.
Well, I have to wrap things up now. As Roger has thanked everyone. It was indeed a very exciting and interesting and informative session. So it's up to me now to just say thank you again to everyone. And we look forward to the next session. And the recordings will be placed on the relevant websites, and we will inform you so as. And just have a good day. And thank you again for joining us. To the panelists, can you all just stay on for a group photo afterwards? Thank you.
Alan, I think you're on mute.
Yeah, so Steve, Roger, and me, I think we need to stay on for a minute. So
Yeah.
thank you, everyone else, and cheers, and we'll see you in another dimension.
Yeah, we're gonna take the screenshot. So Justin, Timothy, sorry, we're gonna ask everyone to put their cameras on, please.
Oh, you want to take a quick screenshot? This
Yeah.
is to prove it to the USAID auditors, Mike.
All you need is evidence of it, right? Paper trail.
It's one of the cheapest seminars anyone has ever attended, I'm sure.
Absolutely.
Okay.
Where's my per diem?
Alan is sending it to you, Mike.
I'm currently operating with the Greek drachma.
I've had a question from colleagues about a recording of this session and how to access that. Is that available?
Yes, it's going to be made available to all the attendees.